It's 3 in the morning, your patient has end-stage renal disease and missed dialysis yesterday. The lab calls with a critical value, potassium, 6.8. You pull up the ECG, tall, peaked T waves, the QRS is starting to widen. The provider gives you 4 orders, you hang one first. A nurse cares for a client with end-stage renal disease who missed dialysis. Serum potassium is 6.8. The ECG shows peaked T waves and a widening QRS. Which prescription should the nurse administer first? A. Sodium polystyrene sulfonate by mouth. B. Regular insulin IV with dextrose 50%. C. Calcium gluconate IV. D. Furosemide IV push. Pause right now and commit to an answer. Guessing after the reveal doesn't build clinical judgment, committing does. 3, 2, 1. The answer is C, calcium gluconate IV. And if you picked B, insulin and D50, you fell for the exact trap this question was built around. Because here's the uncomfortable truth, the right answer doesn't lower the potassium at all. Stay with me. Potassium controls the electrical stability of every cardiac cell. When serum potassium climbs, the resting membrane potential creeps upward, and the myocardium becomes electrically unstable. That instability tells its story on the ECG in a fixed order. First, peaked T waves, then the QRS begins to widen, then the QRS and the T wave merge into a sine wave, and then the heart stops. Look at where your patient is sitting. Peaked T waves, that's step 4, a widening QRS step 5. There is exactly one step left, and that step is ventricular fibrillation, or a systole. So understand what you're actually doing here. You are not treating a lab value, you are treating a heart that is minutes away from a lethal rhythm. The number told you something is wrong, the ECG is telling you how much time you have left. Not every high potassium is an emergency. A potassium of 5.6, with muscle weakness, some paresthesias, and a normal EC, you have time, treat it, but you have time. A potassium of 6.8, with peaked T waves and a widening QRS, the window is closing. Notice what changed. Not the diagnosis, the ECG. The ECG decides the urgency, not the number alone. That distinction is the whole question. Every hyperkalemia emergency runs the same 3 steps, in the same order: stabilize, shift, eliminate. Step 1, stabilize, calcium gluconate. It's first because it does the one thing nothing else on that list can do. It raises the threshold potential and restabilizes the cardiac membrane within minutes. It stands guard over the heart while the slower drugs do their work. And notice, it does not lower the potassium by a single point, it doesn't have to, it buys you time. Step 2, shift. Regular insulin with dextrose 50, sometimes albuterol alongside it. This genuinely drives potassium into the cells, but it takes 15 to 30 minutes, and this ECG does not have 30 unprotected minutes. Step 3, eliminate. Dialysis, kayexalate, loop diuretics. These are the only interventions that actually remove potassium from the body, and they work over hours. Stabilize the heart, shift the potassium, then eliminate it, in that order, every single time. So lock this in. If hyperkalemia comes with ECG changes, then calcium comes first. Protect the heart before you touch the potassium. Say it once, out loud, right now. Because that single sentence doesn't just answer this question. It answers an entire family of NCLEX questions. And here's the pattern underneath it, which matters more than the drug names. When the exam gives you a lethal rhythm developing in real time, it is never asking which treatment is correct. It is asking which one keeps the patient alive long enough to receive the other. Before we take apart the wrong answers, lock this in with 3 mnemonics. First, the treatment order: C, big, K, drop, calcium, bicarb, insulin, glucose, kayexalate, diuretics, dialysis. Calcium is first, it always was. Second, the signs: murder, muscle weakness, urine output falling, respiratory distress, decreased cardiac contractility, ECG changes, reflexes lost. Third, the ECG story, in order: peaked, flat, wide, sign, the T waves peak, the P waves flatten, the QRS widens, and then the sine wave, and the arrest. Recite those 3, and you can answer any hyperkalemia question the NCLEX writes, not because you memorized a list, because you know what the heart is doing at every step. Now the part most videos skip. Why did the wrong answers feel right? Start with B, insulin, and dextrose 50. This is the trap, and it caught good students for a good reason. It actually treats the problem. Insulin drives potassium into the cells and the serum level genuinely falls. If the question had asked what lowers potassium, B would be defensible. But it takes up to 30 minutes to work, and during those 30 minutes it protects the myocardium from nothing. B is your second drug. It is never your first. The NCLEX loves handing you the right treatment at the wrong priority, because a nurse who reaches for the right drug at the wrong moment still loses the patient. Now A, sodium polystyrene sulfonate kayexalate, also a real drug with a real mechanism. It binds potassium in the gut and eliminates it in stool. Over hours, giving an oral binding resin to a patient with a widening QRS is bringing a mop to a house fire. Correct tool. Catastrophically wrong timescale. And D, furosemide. Furosemide eliminates potassium through the kidneys. Read that again, then read the stem again. This patient has end-stage renal disease. Those kidneys don't work. A loop diuretic in a dialysis-dependent patient is close to useless, and this distractor exists to test one thing. Did you connect the diagnosis in the stem to the drug's route of elimination? So notice the architecture of this question. All 4 options are legitimate hyperkalemia treatments, not one of them is a trick. The question was never what treats hyperkalemia. The question was what this heart needs in the next 5 minutes. That is the difference between knowing pharmacology and having clinical judgment. Here's the whole episode on one screen. Screenshot this. On the left, the cues you recognize: potassium 6.8, peaked T waves, a widening QRS, a dialysis patient who missed a session. Individually, each one is a data point. Together, they are a countdown. In the center, the priority action: calcium gluconate IV, with the patient on continuous cardiac monitoring, then insulin and D50 to shift, then dialysis to eliminate. On the right, the outcomes you're watching for: the QRS narrows, the T waves come down, no lethal dysrhythmia develops, and this patient reaches the dialysis chair instead of the code cart. That's the bow tie. Cues in, action in the middle, outcomes out. It is exactly how next generation NCLEX wants you to think, and exactly how the bedside works. And if you remember nothing else from these 8 minutes, remember the ladder: stabilize, shift, eliminate, in that order, every time. Same unit, next patient, sodium of 118, just seized, and there's an order for 3% hypertonic saline hanging on the pump. How fast is too fast, and what happens to the brain if you get the rate wrong? That's episode 2, it's on your screen now. The free hyperkalemia study guide is linked below.